I apologize because of the technical problem. We have a review article on management of deep caries and the exposed pulp. We continue from pulp capping classification. We talked about caries, deep caries lesion, and their how to manage these lesions. And we came into a pulp capping classification, and we'll continue. Class 1 pulp capping is when we have a traumatic exposure of pulp, not because of caries. And in these cases, we don't have some considerations that may be because of the infection or inflammation. Because it is a traumatic exposure, we will use calcium hydroxide, and the problem is over. But in the class 2 pulp capping, we have penetrated into the pulp, and we have a pulp exposure because of a carious lesion. And in these cases, because we are worried about the pulpal inflammation in that site, and also because of the infection that may enter the bacteria that may enter pulp from that site, we need to just disinfect that site with sodium hypochlorite according to the guidelines, and also we use calcium silicate based cements for pulp capping in these cases. We have a question: is pulp exposure a negative factor or not? I mean, is it better to expose the pulp, or we should remain the last layer and just put the pulp cap material on that layer? We have some ideas here. The first one, irreversible damage to the affected odontoblastic palisade and death of the primary odontoblast is inevitable when we penetrate into the pulp. Then, from an operator's perspective, we have two important issues. The placement of the biomaterial in direct contact with the pulp is maybe better, and it may be more beneficial from the operator's point of view. And also, it is easier to evaluate the health of the pulp and to manage it in these cases. You can just see directly how the pulp is and manage it as you have in the guidelines. The other idea is that avoiding exposing the pulp may lessen the risk of bacterial infection, and we can just have the dentin, which is a reservoir of growth factors. And this may help us in the healing process, and is very important in, according to some authors and clinicians. And the last one, we have evidence that the residual dentin layer less than 1 millimeter may be as permeable as we don't have any dentin layer there. And the bacterial challenge is like when we penetrate into the pulp directly.
I have we can't hear you.
Yeah, we can't hear you.
Dr. Nekoofar, we cannot hear you.
Maybe you can write it in the chat. Yeah, perfect.
Yeah.
No, we can't hear you.
Professor Bjørndal, do you hear
Just
Dr. Nekoofar?
From that side.
No.
An ambition. I think technically we cannot use two computers in the same room. So what am I going to ask again? Can you hear me right now, Professor? Yes, okay, sorry about that. My question is about the residual dentin. In the residual dentin, in the last part, you mentioned that the residual dentin layer less than 1 millimeter may be as permeable to bacterial challenges as a pulp exposure. In that case, do you recommend, when we have a very thin layer of dentin, to expose it and put our biomaterial in direct contact with the pulp tissue? Or still, if we still have a very thin layer, less than 1 millimeter, it is better to save it? Because as you remember, especially in American style, they recommend the removal of the thin layer of dentin and doing root canal treatment or vital pulp treatment, rather than just leaving very thin layer. Please give us some clue about that.
Well, I think it's important to have focus on the let's say the preoperative stages of the lesion, and I would actually like to share 2 slides that may makes this point a little bit more clear. And if it's possible for me to share, it would be nice.
Of course. Let me do that right now to ask you to do it for us. Oh my God. Let me do that. Just bear with me, because I need to make you co-host, but it should be possible right now. But
maybe you need to do it on the other computer.
Yes, let's in hostel. Okay, I'm trying that right now. Yes, I make you co-host, so you should be able now to do that. And are you that right now?
Yes.
Good. Thank you very much. Please go ahead.
So can you see the screen now?
Yes, very well.
Okay, so I think it's important to distinguish between what we can start with in the clinic as a rough indication of what is the status, and the division between the deep. We talked about it actually last time, but the summing up of that session, I think, could be done nicely in these 2 slides. The first one shows a scenario of the deep lesion where you still have the radiopaque zone, and a scenario like this where you will have the extreme deep lesion, and even on the radiograph with a thin line, we have a relatively higher risk of bacterial penetration in relation to the tertiary dentin. They may not have entered the pulp yet, but in fact, it's a repeat of the old study from the 60s with Reeves and Stanley, showing that when you are in a situation where the bacteria are involved in the tertiary dentin, you expect quite soon that they will be in the pulp. So to let's say guide a decision whether it's critical having bacteria very close to the pulp would be very nice to remember how was the X-ray from the very beginning. Talking about the differentiation between the extreme and the deep lesion, the residual layer may also be difficult actually in the clinic to estimate. So I think an important point in the decision tree of whether to do the exposure or not should actually be done very early in the diagnostic process. And I mean, if you have an X-ray like this case in the upper right corner, it will definitely be critical to save and avoid the exposure of the bulb. Here, you will need to go one step further. We do not know the histology, but this also explains. I don't know whether you can see my cursor running. Can you see the cursor?
We can see, yes, we can see your cursor as well, yes.
Yes, and combined with the bacterial slide, this of course would be critical, and it will be a disaster if we didn't do the exposure. And this also gives us the thoughts about the benefits of removing some of the tissue during the capping process when we have these deep lesions. When we have this in our minds, I think it would be easier to do decisions. Imagine that you don't have the caries lesion like the one we are seeing here. It may be more natural to try to leave a thin layer as opposed to the case shown in the X-rays. Thank you.
Okay, so if we put them together, just as a take-home message, can we recommend removal of thin layer of dentin, comparing to the way that we just save it for the sake of saving dentin, or sake of we don't like to expose the pulp? However, you showed that in a very clear slide that if we can remove the contaminated part also, that would be very, very helpful. Am I correct?
Yes, again, if you, again, I think it's important if we are talking about trying to treat whether or not to cap a very deep lesion, we are having a magnification to substantiate our findings. And if it's possible to do caries removal and without making an exposure, I think it would be critical in a case like this, even though we say in the clinic that there is no exposure, because we know when it looks like this, we will have bacteria as close as possible, maybe only in the tertiary dentin. But if you do it in a case where you have a deep lesion and where you have a radiopaque zone on the X-ray, it will be possible. Okay? So I'm actually using the X-ray a lot to do a decision like this.
Okay, and do you recommend the use of CBCT for this decision making or not?
No, I think that will be in a very seldom case. That will be too much, I think, for the moment. Then we will need less X-ray disturbances if that should be a routine, I think.
Okay, thank you. Is there any question from the audience? Is there anybody wants to add anything or ask any question? Please go ahead. No? Okay, we carry on. Okay.
For pulp exposure management, we have some approaches. Partial pulpotomy is when we remove 2 or 3 millimeters of the pulp tissue at the site of exposure. Pulp capping does not involve any pulp tissue removal, but in practice, it is common to remove the superficial layer because we believe that that layer is infected and inflamed, and it's better to remove it. Cost-effective analysis and evidence from clinical trials have demonstrated that both direct pulp capping and root canal therapy were cost-effective. Direct pulp capping was most cost-effective in younger patients, usually less than 40 years. In occlusal sites, and in contrast, root canal therapy was preferred in older patients, usually more than 40 years, with interproximal exposure sites. And we have an introduction to materials for pulp capping. A material which is used for pulp capping should ideally have three main characteristics. It should create an immediate seal of the dental cavity. It should be biocompatible and non-cytotoxic, and it should possess bioactive properties. About calcium hydroxide, it has been the gold standard capping material for years, and it is the best known commercial form of it is hard-setting dicol. But the barrier which is provided by using this material is not uniform histologically, and it does not bond to the dentin wall, and it does not provide a good seal. Other limitations include solubility of this material, and also the handling is not favorable, and biological response is questionable to this material. The second material which is introduced as a pulp capping material is calcium silicate-based cements. Recent reviews provide the evidence for a superior outcome for the use of this kind of cements. Alternative MTA-based materials try to reduce setting time, for example, Dentin, and they are recommended for one visit while pulp therapy procedures. The hard tissue bridge, which is formed against this kind of materials, is higher, has higher histologic quality compared with calcium hydroxide, and Dentin has potential to overcome some of the issues of discoloration. We had the problem of discoloration with these cements, but Dentin has tried to overcome this problem. And about the outcomes, a systematic review concluded that the overall success rate in the vital pulp therapy procedures has been reported about 72.9 to 99.4%. And the analysis of the literature demonstrates that we have two kinds of failure. Early failure, which is within days of after the procedure, and we have symptomatic pulpitis. And long-term failures are within several months later, and we have the presence of an apical lesion related to root canal infection after pulp necrosis. And about the etiology, early failures are related to misdiagnosis of the severity of the pulpitis and insufficient pulp tissue removal. Late failures are related to the quality and sealing of the restoration and the mineralized bridge, which is expected to form. But still more robust data are required to say that if vital pulp therapy procedures are a permanent treatment for irreversible pulpitis.
Okay, can you hear me now? Yes or no? Yes, no?
Can you hear Dr. Nekoofar?
Yeah, we can hear you.
Okay. I have a question back to this comment about the pulpotomy, or let's say pulp chamber pulpotomy as the permanent treatment. First of all, again, I want to thank everybody for joining us. I can see a lot of names that they are experts in this field, and they publish already a lot of articles about this topic. I can see Professor Zafar Chehrali as well join us. Thank you very much, Zafar, for that. And I'm going to ask to repeat my question from Professor Lars Bjørndal about that. Because this is a very hot topic these days that people ask this question: can we do pulp chamber pulpotomy by using calcium silicate cement as a permanent treatment comparing to root canal treatment. Please go ahead, Lars.
Lars is muted.
Lars, we cannot hear you. Please unmute your microphone. Okay.
Okay, sorry, can you please repeat the question? Okay, I can't hear you now.
Sorry. Can you hear me right now?
Yes.
I think I should stick with this computer rather than that one. So the question is about doing the pulp chamber pulpotomy by using calcium silicate cement as a permanent treatment. As a permanent treatment, comparing to root canal treatment, because as you know, this is a hot topic these days that suggests
really. So
yeah.
I think it's a very interesting issue, and as you indicated, a lot of you have been doing very exciting research about this, and I think one of the, let's say, outcome measure problems is that we may not have the same chances of evaluating whether we maintain vitality for the pulpotomy. So we have to lean on the fact whether the at the apical region will develop or not. So we may, in a relatively period, actually have a necrotic case scenario. But let's say if we accept that our outcome measure is the avoidance of symptoms and no apical lesion, we are able to make a comparison. But it may not be a fair comparison. But it seems that study are arising showing that the effects are comparable. We still, however, need to have longer follow-ups. And if this strategy is, let's say, exposed to the general practice environment, we have to admit that those data are not indicating a good result on pulpotomy. So there we have some problems in trying to say now this is the way to do it. I think we need more evidence to put it out as a proper case suggestion. But even if you have irreversible symptoms, there's studies around that indicate it will work. Yeah. So it's exciting, but I don't think we are there yet. And that's why, of course, it's still a hot and growing topic.
Lars, I'm not worried about the necrosis, because if necrosis happened or if we have symptoms, we still can do root canal treatment. What we are worried about a lot is calcific metamorphosis that may block the root canal system. What do you think about that?
Yeah, of course, well, it creates job for the endodontists, but that was the plan. It makes, of course, the treatment much more difficult, and you definitely need the microscope, or you have to go for the apical surgery. And I hear a lot of case-related comments that do find these problems. So I think we need good designs. I saw that Dr. Venki Teshbuba. Venki, hello Venki. He is doing a lot in the area of trying to raise guidelines for doing clinical trials and stuff like that. And this area would be so classical to do, comparing pulpotomy with RCT, and we need many of these in order to get a lot of power and to get robust data for sure. Thank you.
Okay, thank you very much. Thank you. Fatima, go ahead.
We lack global consensus, which is reflected in most recent randomized clinical trials, because we don't have any global consensus or tradition currently in treatment deep caries lesion, and also we don't have any high-level scientific-based recommendation that can be made for selecting a gold standard capping material. About new and future expectation of improved clinical evidence, in order to plan a new RCT, there are important rules to be considered. The first one, we should have well-defined inclusion criteria, for example, penetration depth of the carious lesion, choosing identical outcome measures, informed power calculation, central randomization of patients, and data. It is noted that data from published trials reports that revealed they don't have adequate randomization for patient selection. And blinded follow-up examination is another issue that should be considered in future studies.
Okay, so another question raised now, which I'm going to ask Professor Venki also to help us for this question, which is about the quality of the evidence that we already have. As Professor Lars mentioned, we know that Venki is doing a lot of work on publishing some guidelines for that. Venki, may I ask you to turn on your microphone and video and give us your comments about this issue, please?
Can you hear me, Prof. Nekoofar?
Yes, 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 very well.
First, I would like to thank Prof. Lars for this beautiful presentation. Hi, Prof. Lars, how are you? I'm Venki here. Yeah, coming to your question, Prof. Nekoofar. As we know, this is a very controversial topic, as Prof. Lars also mentioned, whether we can do pulpotomy for permanent tooth. But I can see few systematic review published. I think one is recently published in Journal of Endodontics saying that pulpotomy can be done for permanent tooth, especially for inflamed tooth. So that is what my understanding is. But again, the question is, if it's irreversible pulpitis, we can do. Whereas for the apical periodontitis situation, can we do the pulpotomy is questionable. I think so. That is what my understanding. But again, Prof. Lars can explain in detail whether pulpotomy is the right feasible treatment modality for apical periodontitis tooth.
And can we somehow accept or say that this evidence that we already have is enough for us to do such a thing or not? What do you think about the available evidence? Because available evidence and the way that it, as we have seen in the last slide, is not enough, is not possible to be relied on. Are they reliable, you think, or not?
Yeah, the thing is, coming to the evidence, last years back, me and Prof. Gutman did a review on pulpotomy procedure for permanent teeth comparing MTA versus Biodentin. So at that time, we clearly proved in that review, both the materials are good with the current evidence, but it's not a final conclusion. The conclusion is not evidence. So that's why even we concluded in review saying that the future clinical trial is required to show which is the better material for MTA versus Biodentin. That is situation is, I think we published in 2018. But after 2 years, again, we have to revisit on that particular topic, I think.
And what about the material? What do you think about the different material? Can we really say that the evidence can give us some enough information about various materials or not?
Yeah, as we all know, the most of the evidence shows that the MTA and Biodentin is a better material. So that's why in our review, we compared only MTA versus Biodentin. We never picked up any other material on that.
Okay. Professor Mir Mohammadi, I think you sent a question and also a comment. May I ask you to turn on your microphone and go ahead, tell us your comments? Hassam? Yes, please.
Hey, first of all, I would like to say hello to everybody, and yeah, thanks everybody for this lovely presentation. My question is, what would be the benefit of just performing, I mean, vital pulp therapy or pulpotomy in a mature tooth? Because we know that root canal treatment has a high success rate in a vital tooth. And if we have a mature tooth, so what would be the benefit? I know some studies, they say maybe it will be cost effective, but in my clinic in the Netherlands, because most of these procedures are in 2 sessions, so it needs more than 1 session. So compared to 1 session root canal treatment, the cost will be the same for the patient. And the success rate of root canal treatment on vital tooth, it's also 95%. So, I mean, what would be the benefit of vital pulp therapy on a mature tooth?
Okay, Venki or Lars or both of you, go ahead, please.
Well, it's a very good question, and I think the first one would perhaps be if we end up having robust data, then it would be a more simple approach, perhaps. But it's correct; you may need 2 visits. So on that point, you could say it would be more time-consuming, even for the patient. But isn't it a matter of a more simple approach? And if it turns out to be a comparable modality, then the practice environment would be able to do the treatments. But I have to say, before that's information, we are not there at all yet. We still need to show that is that really the case, because I could have doubts in the long run that this will be a comparable modality, but if we stop sitting around and make guess, we need to have data to guide that decision. So right now, I would really recommend for let's say a daily approach, the one that you are suggesting, that at the moment, the best data for the pulpectomy in the vital case is the reason for doing that treatment.
So you mean if you're able to do root canal treatment, it is better to do root canal treatment, at least at the moment, based on the evidence. However, maybe for people that they don't have access to enough equipment or general dental practitioner, they are not competent enough to do such a treatment, it may be possible to do pulpotomy of pulp chamber as a permanent treatment. Am I right?
Not really, because if then you are accepting that this is the best treatment. I mean, if you don't have any possibilities of getting the patient for a specialist, and you don't have the equipment, then it's not the worst thing to do. but you know, the comparison between pulpotomy and cutting studies are not so fantastic in the literature that we can say, is it better to do the pulpotomy? It may be easier to do because the capping procedure, class 2, needs a lot of equipment as well. So no doubt that it's tempting to suggest that the pulpotomy would be a way for a less experienced dentist. But having said that, you still need to really find the orifice of the root canals. You still need to localize them, and if it's a difficult case, you just don't do that without experience and stuff like that. So it's always a little bit critical to say that one treatment is easy compared to another. They are, you still need to have respect for all the stuff you're doing. So it's not a way to say we are jumping over the place where it's easy to jump. You understand?
Yes, very well. I think this is a good thing. Don't jump. Okay, Hussam, please go ahead.
I think that the main problem at the moment is we don't have a clear cut to say, okay, to this extent we need to do vital pulp therapy, and from then we need to do root canal treatment, and it makes it even more difficult for teaching the students. So we can't tell them, okay, to this extent you can do vital pulp therapy, and then from here you can do root canal treatment. So yeah, as you said, it's really difficult to justify. And I completely agree.
Professor Kayahan, please go ahead and give us your comment, because you send your comment, please.
During vital pulp therapy, I think the material is also important. One of the crucial factors using material is the compressive strength of material during pulp cupping. And about other issue, I fully agree with Dr. Hussam. And what is the advantage of pulp cupping if that tooth abutment? This is the question. This is the question. If that tooth is abutment, I prefer root canal treatment. Excuse me?
Yeah, this question is also raised by others about the making a crown on a tooth that we did.
We talked two weeks ago about this issue, and if that tooth is an abutment, I prefer always root canal treatment, because who is doing the pulp cupping? That's an important question too. And if the tooth is an abutment, or social factor is also is important. If you cannot follow up the patient, I think root canal treatment is more predictable than vital pulp therapy. That's my point of view.
Thank you very much. And about the compressive strength of the biomaterial, is it really important? Professor Lars, what do you think? Because the first things that...
Sorry, I'd like to add something more. About the compressive strength, if we take a look at Bogan's studies, you can see that he removed almost over all layer of the pulp, all dentin over the pulp. And in these cases, I think compressive strength is very important. If you remove the dentin layer, expose the pulp more, then you need a material that has a compressive strength.
Okay. Lars, what do you think about the compressive strength? Is it important to select the material if the compressive strength of the material is higher? Do you prefer to select such a material or not?
Of course, I think if we take one thing at the time, I think if you have a huge problem with the tooth substance, I mean, it doesn't make sense. They say, yeah, I saved the pulp, and afterwards you are wondering whether how should I make a build up on this without involving the root. So of course, this is a very this is an important decision before deciding whether to do a capping or not. It needs to be, I mean, in a state where you may or you should avoid a crown. But I have to say, when you look in the literature, a lot of cases and a lot of X-rays shows teeth where you may wonder why the capping was performed. You may see cases where you still is having only a occlusal surface involved, and here you could get very nice prognosis judgment just by using a final restoration in resin. So again, it all, I think, turn back to what is the status when I start. And sometimes you could even argue, has there been caries in this case or what? So of course, if you have a very developed and severe situation, it would be very critical not to think about post-core and crown versus a case where you still may only have suffered the occlusal surface. And I think that discussion is quite often not exposed in the literature. So again, I think in future studies, it would be very informative to, instead of saying, okay, we did a cap because of a deep lesion, stop. We actually describe how was the deep lesion, how many surfaces were involved, and stuff like that. So quite often, I think when we have an unclear background to make proper decisions. I don't know whether I'm making myself clear.
Yes, but very clear. This is a very important thing. The number of surface involved, the
yes,
complexity of the carious lesion,
yes,
and the extension of the carious lesion. We can add all of this.
And then, of course, you can always then find borderline cases that can divide the audience into 3 or 4 groups. But I mean, as a starting point, I think we should seriously discuss pulp capping cases where you perhaps only have the occlusal surface involved. Do you have an approximal surface on older patients? I mean, then it already starts to get critical. So I mean, the case selection that we often talk about is, of course, crucial here as well.
Yep, thank you. And Professor Kochar, Professor Rohit Kochar, please turn on your microphone, because Professor Kochar somehow believes against what Hesam mentioned and is going to say that. So, Rohit, please go ahead.
Hi, good afternoon to all.
Yeah,
can
we
you
can hear you.
Okay.
Well.
Okay, now I just said that if you decide to go for pulp capping or you don't decide to go capping, as Professor Nekoofar just now said, that depends upon so many factors, you know, the number of surfaces involved, the depth of the lesion, and the thickness of the remaining dentin, that is all very important. But what I said was, I'm trying to say is that if you can avoid the endodontic treatment, you also avoid the patient taking through a lot of mishaps which happen during the endodontic treatment. That is what I meant. So it is preferable to be conservative, as much as conservative we should be. And of course there will be less revenue involved in that, but then definitely you will be ethical.
Yeah. Okay, Hesam, as you heard, Rohit raise another issue, which is about the mishaps and let's say accidents during the root canal treatment. Because if something happened during, for example, pulp capping, we still have the possibility to do root canal treatment. And to avoid this type of mishaps, maybe better to do vital pulp therapy first, and if it's not successful, then we go ahead doing root canal treatment. I'm just repeating what Rohit mentioned. It doesn't mean that it is my opinion or not. Hassam, go ahead, and then we ask Lars.
On one hand, I totally agree, and I understand the comment, but on the other hand, it's really depend on the clinician. To me, as an endodontist, I can do some cases just with blind eye root canal treatment, and really, I'm performing vital pulp therapy, and to me, vital pulp therapy is more difficult. I spend more time on vital pulp therapy rather than performing root canal treatment. So then I'm just saying to myself, is it rational to expend more time on a vital pulp therapy to save the vitality of the tooth? And I know if this patient goes to another clinic, the first thing they do, they make a radiograph and they perform root canal treatment on that tooth. That's why I think the decision making is really difficult. And yeah, I mean for a mature tooth, perhaps performing root canal treatment would be a better option. But I understand it's really negotiable.
Okay. I'm going to ask Viresh Chopra, because I know Viresh did a lot of study on different biomaterials to give us some idea and some clue about the type of biomaterial that we should use. Viresh, go ahead, please.
Yeah, hi, Professor Nekoofar, thank you so much. Am I audible, I think? Yeah. I would say I would like to say thanks to Professor Lars for such a nice presentation, right? And my view is that it seriously depends. It's a multifactorial decision. It's not based on a single decision. So probably clinician who is on the driver's seat has the best glance at that point of time to decide whether he has to go for vital pulp therapy or root canal therapy, right? Now challenges are present in both the treatments. If you see vital pulp therapy, probably it depends on, it's a very sensitive procedure, right? And a lot of things have to be taken care of. And on the contrary, if we go for a root canal therapy, yes, of course, endodontic mishaps can happen. A lot of accidents can happen. Root canal anatomy is challenging, but at these present days, we have armamentarium in which we can take care of endodontic mishaps also. And we have biomaterials like bioceramic, calcium silicate cements, which probably help the body in healing in much better than comparison to other materials in previous days. And right now we have on our screen one of the gods of MTS, Professor Nekoofar, who generally is a strong man in MTS. So who knows better than him, right? So I feel these days a lot of things can be taken care of, but as Dr. Hassam said very rightly, that it is a very multifactorial decision and it's an ongoing fight between vital pulp therapy and root canal therapy, what we should perform at that point of time. We have to consider that both are sensitive procedures, and we have to rely on our decision at that point of time, right? But if we are doing, probably we should look towards using the best of the material in terms of bioceramics or calcium silicate cement, which are hydraulic, and they will help us in and taking care of the way we are doing the procedure, because the steps we follow to perform that procedure are much more important, where the insult to the biomaterial should not happen, right? And the sensitivity of the material as well as the protocol should be followed to have a good success rate. Now, when I say sensitivity to the protocol should be followed, this also puts into consideration that while doing the endodontic therapy, that if we go for a root canal therapy, then that protocol should also take into consideration the challenges we will face doing the endodontic therapy. We should not just jump into and then break an instrument or do a perforation or something like that. Then everything, and the most important part in this is the first factor that comes into play is the operator's skill while doing all these things, right? If we don't have the operator skill, then probably whether we do a vital pulp therapy or an endodontic therapy, both protocols, if we don't follow the protocols, both will fail. This is my viewpoint.
Okay.
Thank you very much. Lars, that's vital pulp therapy is working, full pulpotomy of pulp chamber. But what we discussed now is about the skills of the dentist. And Hesam, Viresh, and others emphasize that if we are not competent enough to do root canal therapy, we may decide to do vital pulp treatment. But you mentioned that it is not ethical to say that, because we need to find out this works or both sides are working, and then we decide what to do. Can you put together all of this idea and give us a take-home message? I know it's very difficult to.
Yeah, but I think actually it's important to say that what have happened since, let's say, the outcome of calcium silicon cement, the operating microscope, I mean the George Bogan study, showing that you were able to push the indication that you actually could do capping on very deep lesions, because before that it was not an issue. So I think it's just a way to take a result like that, even though it was observational data. I think it was important to say that, okay, if you are able to do that in the clinic, having the right tools and stuff like that, you can do a lot of nice stuff with the vital pulp therapy. But it is difficult, and that's why if we end up having trials with very keen clinicians showing that the capping is comparable, I mean all sorts of capping is comparable with the root canal treatment, it's still a task then to say, okay guys, go out and do it. Because if they don't accept a septic, they don't know what Rotterdam is and stuff like that, you know all about that, then forget about pulp therapy. I sometimes I tend to say that the vital pulp therapy, we talked about that 14 days or 2 weeks ago, that we have a system where we as endodontists very seldom do the capping because the general practice have done the decision for us. But if we have a system where we actually are able to do the first approaches as endodontists, then you would have a very much or better platform for making those treatments. But do we end up having it like that? That's a question that it's difficult to answer, because also countries around the world have different systems. There was a comment about, if I do that, then my next dentist will do another treatment. And I mean, we tend to avoid or prevent that by having the tradition of forwarding patient files. So the next dentist, in theory, know what has happened, but it's also a difficult issue when you send a treatment further. How will those treatments be interpreted? Is it like, oh, what have been doing here? Let me do the root canal treatment, or oh, this is delicate treatment where the dentist has tried to avoid a root canal treatment. So again, the transportation of information from one dentist to another is also critical. A lot of stuff, but trying to put it into one take-home message. We still need, before all this becomes reality, we still need to do more trials comparing different interventions, because that would be the starting goal. But imagine we find studies saying that, well, over the years, the pulpotomy is not working compared to a root canal treatment and stuff like that. So I think that would be the most robust way to approach, but it's hard work to make clinical trials. It's hard work, but we can only say that it's the only way forward. Thank you.
Thank you. Professor Sharif. Professor Sharif sent a comment and I asked him to speak about that himself. Professor Sharif, are you connected? Because suddenly you disconnected. Professor Sharif mentioned that in accordance to Dr. Anil Kishan, work on vertical root fracture, he thinks giving the vital pulp therapy a chance is better for the long-term survival of the tooth. Again, Lars, please, what do you think about the consequence of root canal treatment as vertical fracture? We unfortunately see a lot of them, especially if they need, for example, post inside the canal. And if vertical fracture is one of the consequences, maybe we can say that, okay, vital pulp therapy can be the first line of the treatment, and then we go ahead doing root canal treatment. I'm sure Hesam is going to give us some clue about that as well. But what do you think, Lars, first? And then I'm going to ask Professor Kazandak to give us her point of view as well. Lars, please. Lars, please unmute. Yes, now.
Well, it's not my main field, so to speak, but I guess it has to be in the very early phase of a vertical root fracture. I think it would be important to visualize in the microscope where is this fracture, where is it running, and if it is heading for a root canal entrance, I would say we have a critical issue. So it's also about diagnosis, if I understand the question right. But are you only in the roof?
I think Anil Kishan showed that there are a lot of vertical fracture after doing root canal treatment comparing to vital pulp treatment. That is the case that I think Sharif and Anil wants to raise.
Okay. Yeah, well, I can't add any comments on that story.
Okay.
Because
Hesam?
yeah.
Okay, Hesam.
Again, it's difficult to because when we look to the studies of having micro cracks or fracture in the tooth, performing root canal treatment, there are very studies done. There are very laboratory studies, and these studies methodology. They have methodology problem because they made a slice, and we know that we at the moment we put them in the garbage. So at the moment we accept only the macro CT studies, like what Dodeus did, and actually a study of Dodeus showed that we do not have more chance of micro cracks or fracture performing root canal treatment, but when we need to look at the clinical data, and it seems that clinical data shows that we have more root fracture by this. We have root canal treatment. So yeah, we have risks by performing root canal treatment, but it doesn't mean we don't have risk by performing vital pulp therapy, because with vital pulp therapy, it's our success, or we have to wait and later we see just a periapical radiolucency, and then we know that the prognosis is already jeopardized when we have periapical radiolucency. And the other example is when we need to place a post, so there is no discussion because we can't perform vital pulp therapy. When we need to place a post, then we need to do root canal treatment.
Yeah, I think this is the extension of caries, Hesam. I think to answer this question, what I can add is the extension of caries is the most important thing. As Professor Lars also mentioned that the surface, the number of surfaces involved is important. So if the number of surfaces are involved, then we can say that, all right, in that case, we need a crown. So we need to avoid, as Professor Kayahan mentioned. And also if we have extensive caries, obviously this is also susceptible to fracture. It doesn't mean that root canal treatment make it prone to fracture. In reality, the extensive caries make it prone to susceptible to fracture. That is the case. So we shouldn't confuse between this data. I think Wenki is going to give us a lot of clue about the way that we need to interpret the data. The problem is sometimes we interpret the data in a way that we like to do that, rather than looking at the data in a way that they are in reality there. I don't know, maybe I'm somehow exaggerating the issue. But, my idea is we need to be very careful about the etiology of the vertical fracture. Is it root canal treatment or is it extensive caries? That is the case. That's the case. And my other comment, because Lars has mentioned a study of Bogen, so a study of Bogen 2008, and also we have a similar study in 2015 by Miguel Marcus. So they are almost the same studies. They showed a really good success rate, but to me, these studies doesn't have a good external validity, because the case selection, treatment, evaluation, everything is done by one person. So, this is evidence, but what kind of evidence? And the other vital pulp therapy studies are also, if you look at these studies, they are mostly done by the same group. So I mean, I totally agree with Dr. Bjørndal. We need to have better scientific support, and we need to design a good clinical, just randomized control clinical studies to justify. Thank you, Hesam. Professor Meric Kazandak. So you raise a question as well and a comment. Please go ahead. Lars is ready to answer all of that.
Thank you very much, Dr. Nekoofar. Yes, I raised my question that if we do the multi-pulp therapy, we may avoid some mishaps, and the guidelines and our recommendations are for the dentist. So maybe we can differ the clinician and specialist and general dentist as well. And it comes again the skills of the operator, I think.
This is a very important issue. You need to give us a very clear answer to that. Is it possible to have different guidelines, one for general dental practitioner and one for endodontist? Is it ethical? Is it biological or not? Lars, please.
I think actually the reason for making class 1 and class 2 is actually a kind of answer to that, because if indirectly you can say, because if you don't have a microscope and then we lean on the protocol, and I can only agree with his point about that these studies are observational studies that show that if you do a proper pulp capping, you can do very crazy treatments. Sorry to say that, but and it works. So if you are not in the position of having a microscope, then forget about class 2. And you should forget about capping caries lesions, because as we show in our trial, comparing the stepwise with the complete excavation, we actually did the follow-up on the capped cases And there we saw the terrible results. People trying to do the best they could, but using a class 1 approach. So you can say that in reality, we do a kind of border between that. And then you can say, is it ethical? Well, then you can say that the general dental practitioners should then make a referral. But if this guy has a waiting list for 6 months, then it doesn't make sense. So we also need to be practical. So that will, in the end, often mean that, well, it's a root canal treatment instead. But in reality, the class 1 and class 2 is actually, you can say, behind the lines, the class 1 would be safe and nice for general practitioners, but the class 2, you could say, how many would actually be able to perform the protocols as the protocols that we look on when we say it's possible. So if you can't do it, forget about it. Does it make sense?
Okay, Marich, is that okay? Do you want to add anything?
Yes.
Okay, good.
Thank you very much. It was very clear.
Yeah, that was clearer than before, to be honest. So, I'm going to ask Venki to answer a very important question. Do you think that if we want to create some new evidence in the future, the etiology is important or the outcome is important? Because sometimes we confuse between the outcome and the etiology in terms of extension of the caries. Some people say that, okay, root canal treatment is not good because we have very worse outcomes such as vertical fracture, such as blah, blah, blah. However, they forget to mention that when we have extensive caries, when we need, for example, post-insertion, when we need very complex restoration, that would be the reason. So this is the confusing between the evidence. And after you, I'm going to ask Professor Kimaras Nazari to give us some idea about the available evidence. And then we ask you again to tell us about, can we rely on those evidence or not? Venki, please.
Okay. Yeah. Coming to
Venki, you go ahead first, please.
Yeah. Coming to your question, Prof. Nekoofar, I suggest both etiology and outcome measure is both important. For example, etiology for this type of situation might be two things. One is caries and another one might be fracture. So the whole scenario will be changed because of your etiology. Same way, the one more point which I would like to think is very important is the maturity of the tooth, whether the tooth is fully formed or it's open. Again, these two things might vary. Another very important I would like to think is the outcome. What are we going to measure? Are we going to see only immediate post-op pain, or the formation of root, or the outcome of the whole success of the treatment after 1 year's time or 3 years time or 5 years time? So in case if you want to do any randomized clinical trial, these things has to be very focused. For
what
example,
about the calcific metamorphosis? Venki, sorry to interrupt you, because you didn't mention calcific metamorphosis, which is one of also the very worst outcome for us as endodontists.
yeah, no, for example, I'm telling, so each and every outcome plays a key role. So while doing the randomized clinical trial, it has to be very important, which is our primary outcome, and we have to mention what are all the secondary outcomes. So this both plays a very important in conducting any randomized clinical trial. As me, Prof. Lars involved in releasing one of the randomized clinical trial recently, couple of issues back. So in the results section, we have clearly mentioned primary outcome is important. Similarly, the secondary outcome also is very, very important to emphasize. Not only is one outcome is important for randomized clinical trial, so you have to take it up the next level also, so that it will give you the whole holistic, clear image picture of our aim of our study.
Thank you. Kimaras, you please.
I will say hello to everyone. As everyone said,
Louder, please, Kimas. Can you speak louder?
Okay. As many colleagues mentioned different factors that involved in vital pulp therapy, I already said that many articles, many issues are mentioned in different journals. But as Dr. Hessam had said, it depends on your skill, your experience. Be familiar with different biomaterials and the level of the tooth structure, such as one surface, two surface, three surface. But one of the main problems that we have is infection control. If you do any treatment under clamp rubber dam isolation, it is possible to do everything that you want. For example, if you do vital pulp therapy without any clamp rubber dam isolations, it equates to fail. Yes, it's a fact. But when you have a good isolation, you can prevent microbial invasion in different parts of the tooth. So I think after gaining a good isolation and using different disinfectant around the tooth, it is possible for us to cut or amputate vital pulp as any different level that you want. In the surface, we have the pulp capping. In the orifice of the canal, we have the coloring. Also, it's possible to have the partial pulpotomy. It means to remain about the 3 meters of the vital pulp at the apical. It's possible for us. And it's better than before because we have many different materials. And about the materials, I think the biodentin is the best material that we can use for this purpose because it's so resistant to compressive strains about the 2000 PSI, I think, after about the 10 years setting. And also, it's very, very important material because it can introduce pulp tissue to promote odontoblastic-like cell generation. And I think it depends on skills, experience, and also knowledge, and be around the best colleagues that we have. It will help us to do it better than before.
Thank you very much, Kimas. Lars, I'm a bit worried about choosing the material because evidence is not enough, again, to support about comparing, for example, biodentin to others, or maybe we can find something about just, for example, some biological results, but not the clinical evidence. What do you think, Lars, about this issue about selecting a particular calcium silicate semen? Do you think, do we have enough evidence to rely on or not? Lars, please.
Yeah, it's difficult because we have new modifications of the material coming up in a very fast speed. So it's difficult to make a serious evaluation of these materials. But of course, biodentin and the old MTA has huge evidence in the lab. And I think we are about to say that calcium hydroxide has been a good friend for many years. And in the clinic, it's still proven to do a lot. But I think we have to say that the group of hydraulic cements has more and more space in the future. Which particular one, I don't have any comment on that.
Okay.
So
Now, okay, Lars, thank you very much. Now we have 5 minutes for you for the conclusion, put everything together, and then we are going to put our hand together for you and say our appreciation to you. Now you have 5 minutes.
Okay. No, but first of all, of course, I have to say thank you for inviting me to this webinar and this journal club, and thank you for the nice presentation of the review. It was very easy to get the slides, so that was a very good job. Thank you for that, and I'm very honored that I was picked out for this session.
So are you happy to give her a good mark at the end of this course, because she is our resident, she needs our mark? And you are, please tell us, can we give her something like 80 out of 100, or do you want to give her more?
Well, we have to reach 91, huh?
Oh, great. Okay. 91. Thank you.
Okay. No, okay. You know, there always needs to be space for improvement without making details about that. Okay.
Okay.
No, no, but I think you were actually summing up yourself very nicely. That a lot of stuff.
My mark is 100 now. Then, so you give me 100.
No, but Dr. Kumars were really making a nice point about if you can control the aseptic very much and a lot is possible. The case selection is important. And I think the prehistory of the caries lesion, I would be very glad if that was a standard paragraph in future capping studies, really describing in detail the penetration depth of the caries lesion. That will bring us, and I may not care if people are capping cases where you say, okay, maybe that was not needed. We gain very important information, because we may end up saying that, well, if you cap a lesion the half of the dentin thickness, you actually see a better prognosis than if you do it in a profound, deep, extreme scenario. And that is right now maybe something you can say, of course, that have to be like that, but we don't have evidence in detail indicating that. And of course, it's also important to say that we don't have the true story by one X-ray. It's only two-dimensional, but it's a nice starting point. And you may end up saying that in this case, I was actually able to provide a perfect excavation without perforation. And in another case, the cavity were completely different. So of course, the adding up what you see in the clinic with the X-ray, important. So I can only end up saying that the community will only welcome nice performed randomized clinical trials to gain more evidence. What happens with the trials, we do not know when it arrives to the practice environment. You know, general dental practitioners are very difficult to change. They are like an old horse. They do what they want to do. But if we have more and more evidence, it might be difficult to obtain a strategy that is outdated. So we all work for a better quality of treatment, better evidence. So it has been nice to be a part of this session. Thank you.
Thank you very much, Lars. I don't have enough word to say thanks to you, because you did a lot of good publication, you give us a lot of good information. And in the world of endodontics, we all owe you a lot. And thanks for accepting our invitation. I know you are very busy. And thank you very much for joining us. That was amazing to have all of you around. So what am I going to ask everybody to turn on their microphone, and if possible to turn on the video and put their hands together for Professor Lars Bjørndal and say thanks to him. Thank you very much, Lars, for your help, for your support. Thanks a lot. Thank you very much.
Okay. Bye-bye, Winky. Bye-bye, all. Bye-bye.
Bye-bye, and thank you very much.
Please take care.
Follow
Bye-bye.
us.
Thank
Thank you very much, Winky. Thank you very much, Hassan.
Bye-bye.
All of you, Professor Kayahan, Marriage, and all of you. Sorry, I cannot mention all of the names. And thanks, Lars, for that. And stay with us in our website at APEC and TUMS. From the next session, we are going to have Appraise To Raise sessions as a common work between APEC and TUMS. See you soon, and goodbye to all of you. Thank you very much.
Bye-bye. Bye-bye.
Bye-bye. Bye-bye.